Sandberg. I really appreciate you joining us this evening. I just wanted to say thank you for taking the time. The purpose of this presentation this evening is just to provide a little bit more information to anyone on the webinar about specific issues that oftentimes will affect men, particularly in survivorship after treatment for prostate cancer. Primarily, we'll be talking this evening about stress incontinence and erectile dysfunction. It's also important to note that a lot of men, including those who I treat, do not necessarily have a history of prostate cancer or treatment from prostate cancer, and they can still experience these issues nonetheless. And so it's not specific per se to that population, but that does carry a large portion of a lot of the men who I treat. And so I just wanted to kind of start off by introducing myself a little bit. Again, my name is Jason Sandberg. A little bit about myself. I was born in Chicago, Illinois. I grew up in South Florida in Boca Raton. I lived there all through my early childhood years in high school, and then went off to college at Northwestern University in Evanston. There obtained a degree in biomedical engineering. Then went on to do medical school at Northwestern as well in downtown Chicago. That's where I met my wife, who's also a physician. She's a pediatrician. And after going through residency training in North Carolina and then fellowship in Iowa, we moved to Michigan, which is where she's from. And we've been here for the past 5 years, raising two daughters, a 2-year-old and a 4-year-old. So we plan to be here for the long haul. And if anybody during or after the presentation would like to come see me in the office for any issue or see any of our partners as part of Michigan Institute of Urology, we plan to be here for the long haul, and we'll take very good care of you. I do specialize in surgical reconstruction of the urinary tract, particularly from the bladder downwards. That includes surgical treatment for stress incontinence. It includes penile implants for erectile dysfunction and all the medical treatments in between as well. I also see men for urethral stricture disease. Sometimes occurring after trauma, but other times from other medical conditions. And then I also do a fair amount of general urology, treating enlarged prostates, kidney stones, that sort of thing as well. I see patients currently in Troy and in West Bloomfield, and we can always find between those two locations, hopefully something that's convenient for folks if that's what they are interested in, if they like to come see me for any reason. So I wanted to jump right in and just kind of talk a little bit about the focus of the presentation, which is prostate cancer survivorship. We oftentimes will talk to patients early on in a diagnosis of prostate cancer about the treatment for prostate cancer, and rightfully so. The first time a patient hears that they have cancer, it's a very heavy moment for obvious reasons. And the first thing that we're always thinking about is, well, what do we do next? How do we treat the prostate cancer? How do we achieve cure? Right. But then after the fact, after that prostate cancer has been treated, men are often left with side effects from those treatments. And so, I always like to introduce the concept of survivorship to my patients as soon as possible, oftentimes even before a treatment has taken place, so that they at least understand the implications of those treatments. And then if they experience these side effects, but because in no way is it guaranteed, but we know that it can have an effect if they do experience things like erectile dysfunction or urinary incontinence, we've thought about it ahead of time, and they understand what the options are for treatment and what that means too. And oftentimes thinking about those things ahead of time will also help guide their treatment decisions. So the important thing to understand too is kind of a dovetail off that is, certainly treatment of cancer is extremely important. That's our primary goal here. But we also want to have an understanding with our patients that sexual wellness is very important. It's important to our quality of life. It's important to our partner's quality of lives. And it's also important to our psychological quality of life. And, by treating a man physically, you can also treat a man emotionally and spiritually in a lot of ways. And that's where, I really became interested in this work, because it can make a big difference in a man's life. So the other thing I'd like to stress to patients and to anyone on this webinar is it is not something to be ashamed of. It's not something to suffer with, in silence. It's something that we try to help bring out into the open, in our visits together, talk about, very transparently, and help you address your concerns. So I want to focus first on erectile dysfunction. Erectile dysfunction is very, very common after prostate cancer treatment, and particularly when you look at men who've had a radical prostatectomy or surgical removal of the prostate for prostate cancer. Some numbers and studies that have been done are as high as 75%. The variability there on the screen between 25 to 70% oftentimes just reflects the different definitions of erectile dysfunction. And that might range anywhere from a man who still can get erections, but are significantly weaker than they used to be, maybe less inconsistent, or I should say more inconsistent than they used to be, all the way to the man who can no longer get any erectile function at all. This can also affect men who have had treatment for prostate cancer with radiation, cryotherapy, proton beam therapy, things like that. Now, I also tell guys, though, it's very common for guys to have problems with erectile dysfunction immediately after prostate cancer treatment. And it is possible for nerves to recover. It is possible for erectile function to recover for an entire 12 months after that treatment concludes. Unfortunately, not every man will recover that function, but we do tend to delay the most invasive treatments such as penile implants until that year mark, just because we know that there can be significant recovery, and we don't want to do anything that's irreversible to a man who might otherwise recover his function. One question from a participant here is asking, do all treatments result in some form of incontinence? And the answer to that is not necessarily. I think all prostate cancer treatments have the risk of resulting in incontinence, but the fact of the matter is that not all men will develop that. And we're going to talk about that a little bit more once we get to the incontinence portion of the discussion tonight. Just to be crystal clear about things, I mean, we sort of define erectile dysfunction as the inability to achieve or maintain erection firm enough to have intercourse, right? So I do talk to plenty of men where maybe they are having difficulty with erections and maintaining firmness, and they can be sexually active with their partners in other ways, right? And that might include manual stimulation, oral stimulation, but they're not able to, penetrate or have, penetrative intercourse. And we talk about that because for some men, the goal is penetrative intercourse, and for other men, it's not. And so it's also important to understand that you can have a sexually satisfying life without the ability to have penetration, but that's not true for every man. And that's why it's a very personal thing when we make decisions about treatment. What is right for one man in the same circumstance and the same symptoms may not be right for another man. With that said, 1 in 5 men will experience erectile dysfunction throughout their lifetime, and that incidence goes up with age. My general rule of thumb is once you reach the age of about 50, if you take the age that you're at, that's about the percentage of the population who is experiencing erectile dysfunction in some degree or another. So if you're 70 years old, there's about 70% of men that can have erectile dysfunction. And so I also stress to men, whether or not it's as a result of prostate cancer treatment or not, it's a very common thing. In some ways, it's a natural part of aging, but it doesn't mean we have to accept that. And that's why we offer the treatments that we do. Common causes of erectile dysfunction, right? So we talked a little bit about the prostate cancer treatments, but it is true in general that outside of prostate cancer, 70% of patients with erectile dysfunction do have other medical comorbidities that might range from peripheral vascular disease to diabetes to obesity, a history of smoking, high blood pressure. These are all conditions that can adversely affect your organs, such as your kidneys, your liver, your heart, and also your penis. And so in similar ways that men may be on medications for those other conditions, you can see how that's reflected in the organs of your body, and the penis is another organ that can be affected. We also tend to do, we do a very thorough evaluation to look at other possible causes, which could include medications. Some medications men need for other conditions, but we know that we might be struggling with erectile dysfunction because of it. One other participant asks, what effect does hormone treatment have? And it has a huge effect. When we talk about medications, especially men who are on androgen deprivation therapy for a treatment for prostate cancer, that has a huge effect on erectile dysfunction, has a huge effect on libido. It has a huge effect on overall energy. What we're doing during androgen deprivation therapy, which is oftentimes an adjunct to other prostate cancer therapies is we're giving men medications that will essentially reduce their testosterone to zero or close to it. And so, back before these medications were, invented, we would actually remove men's testicles to completely knock down their testosterone. And so you can understand, if you're getting medications that's essentially having that same effect, it's going to severely affect, your sexual drive, your ability to have erections, and all of that, all the above. Things we also talk about are ways that we can try to reduce those health risks, right? I mean, these are things that we probably have been hearing from the time we were children growing up to, exercise, keep your body active, eat healthy, if necessary, depending on your body, try for some weight loss. I think one that's increasingly being recognized is, to reduce stress and understand the importance of sleep. I see a lot of guys who I think have a level of sort of chronic stress and to some degree anxiety related to their jobs, related to their home life, related to the fact that they don't sleep well. And that disrupts our circadian rhythms. It puts our body into an almost chronic state of fight or flight. And your body's sort of thinking, hey, why am I worried about getting an erection when, my cortisol levels are through the roof because I'm trying to survive. At least, that's not, literally what's happening, but that's how your body's feeling. And so that can have a big effect too. So we talk about that with men as well. And so I wanted to talk a little bit next about why prostate cancer treatment can cause these symptoms with respect to erectile dysfunction. So, this diagram that you're seeing here really kind of highlights the proximity of the prostate to the nerves that are responsible for erections. When your prostate's removed, there's what's called the neurovascular bundle that runs essentially around, if you think about it as a clock, it runs around 5 and 7 o'clock or so on the lateral aspects of the prostate. And the surgeon who removes the prostate, we have a pretty good understanding these days about where those nerves are. In some cases, due to the extent of a man's prostate cancer or due to what that prostate looks like in the midst of surgery, if a surgeon is forced to take those nerves and remove those nerves. And that's in order to gain adequate cancer control. But as a consequence, those nerves are understandably damaged, and that can be what leads to problems with erectile dysfunction. When the prostate's removed, then we have to sew the bladder back to the urethra to kind of bridge that gap from where the prostate used to be. And so in a lot of cases, that's why we also see recovery of these nerves over time, because as that connection heals, those nerves are going to heal back together too, and hopefully regain some function. But for every man, that's a little bit different. So in general, there's a lot of different treatments for erectile dysfunction. A lot of those treatments, a lot of men are probably, familiar with. Pills like Viagra, Cialis, Levitra, very, very common. There are some newer companies on the market, such as Hims and Rose Sparks, that offer online consultations with the sort of marketing benefit of being discreet. You don't have to leave your home. You have an online consultation. But these companies, while they are supplying legitimate treatments, they're essentially providing the same treatments that have been on the market for decades. A popular one I'm asked about these days is Rose Sparks. That's a combination, generic Cialis and Viagra together. And so I always encourage guys to explore that if they'd like to, but those are treatments that we've had for a long time. Some of the newer things on the market include low intensity shockwave therapy to the penis. This one, I think, has its place in certain circumstances. If a man comes to me and has had his prostate removed and he's getting no semblance of any erection, this treatment is not going to do the trick. It's not going to turn things around. But for the man who has relatively mild erectile dysfunction, maybe he's taking Viagra or Cialis here or there, it can be an appropriate adjunct to try to help improve erections, and it's been proven to do so. We also will sometimes offer and recommend to men, especially after prostate cancer surgery, to use a vacuum erection device to draw blood into the penis to keep the oxygen flowing into the erectile tissues as you recover in those first 6 to 12 months. We can do injections directly into the penis as needed, which we teach men how to do when pills or vacuum erection devices or other things are not working. I have a lot of men who do use those injections, and there's certainly pluses and minuses. If you've never done it before, understandably, in the beginning, you may be apprehensive about having to poke yourself in the needle in the penis. But most men, I think, find that it actually works fairly well. In those who don't, though, or in those who have been doing it for a long time, and sometimes the efficacy of it wanes, then, I oftentimes will talk to men about implanting penile prostheses. And that is something that I have a specialization in. I did extra fellowship training in. And it's something I'm really passionate about because it does take men from a place of inconsistent directions and wondering, why is this not working? Hey, I'm going to give myself an injection or take a pill, and I'm going to wonder, is this going to be the time it works, or is it the time I'm going to have to sort of, stop our sexual activity in frustration, let myself down, let my partner down, and understand those frustrations. The implant can be a very important tool to help restore that erectile function and do it in a way that is consistent and that doesn't leave a man wondering, hey, is this going to work tonight or not? I talked a little bit about the pills. I think most folks are fairly familiar with that. The main thing that we worry about when we, prescribe medications or comorbidities, making sure that you don't have any other contraindications of other medications that could cause problems for you. Sometimes men do get side effects with them, and even though they work, the side effects are so sort of severe that it's not pleasurable, and they decide that it's not worth it and they don't want to take them, and that's understandable. But that is typically where we'd start. We do have, as part of Michigan Institute of Urology, our own pharmacy located at our Troy office on the Town Center Drive. I mention this just because some men, depending on your insurance, they do get a lot of benefit from pills, and yet insurance is only going to cover maybe 6 pills a month. And then when they do, it's expensive. And so we offer competitive pricing there. And so I would just mention that because if you are paying high amounts of money currently for things like tadalafil or sildenafil, we can offer alternatives to you there. The vacuum device, as I mentioned before, oftentimes will go hand in hand with oftentimes a man using a pill. I think it can be a good adjunct. Oftentimes I'll also recommend a man use a ring at the base of the penis to, the pump will draw it in, the ring will help hold it in and keep the blood intact. And certain men have tried this and they absolutely hate it. Other guys try it and they don't mind it, and they'll continue to use it. So it's just one of those things. I tell every guy, I want you to understand all the options. You get to pick and choose what you want to try and what works for you. So it's just important to know actually what's out there and what the options are. Same thing here with the injections that we mentioned before. The biggest downside here is you've got to refrigerate the injections. They typically expire after about a month, not meaning that they're going to be dangerous, but they might not work quite as well. And you've got to be willing to give yourself that injection every time you want to be sexually active, about 15 minutes or so beforehand. And it does, though, give a pretty good erection to most men who try it, though not all. Over time, you can form scar tissue that can sometimes cause curvature of erections. Certainly, it's not the end all be all in terms of erectile treatment, but I've got a lot of patients who use them and are quite happy with it. The low intensity shockwave therapy, we do offer this as well through our sexual wellness clinic called Redeem over in Birmingham on 14 Mile Road. I think the benefit here is there's really no downsides to this, quite honestly, other than cost. The biggest downside is not covered by insurance, but there are no side effects. That's not painful. For some men, especially who are on kind of the less severe end of erectile dysfunction, it can be very, very helpful. And I've had guys be able to completely come off of pills after doing this treatment, and that's been, very, very effective. So for the right person, I think it can be useful. So I do want to talk a little bit more about implants, just because I think that's one of the things where, a lot of guys come to see me when they get to the point where they've tried all these other things. Oftentimes other physicians, their primary care doctors or other doctors will already have tried pills. They've already tried injections. You don't necessarily need to see a urologist to have those things done. But if you get to the point where those things are not working, then yes, we need to have those things done. We need to have at least a discussion about putting the implant in. And again, it's not right for everybody because some guys don't want to have surgery, right? They're not willing to undergo another procedure to have, this implant placed. But for the right patient, it can be a sort of a life-changing experience for them. in general, there's a couple of different types of implants. There's, broadly speaking, inflatable implants, and there's semi-rigid or malleable implants. The semi-rigid or malleable implants are, somewhat stiff. They don't actually inflate or deflate. So a man is kind of always walking around with a semi-hard erection. But it does work quite well, especially for men who might not have the hand dexterity to actually use or activate the implant that's inflatable. So there's some ease of use there. But I would say 95 or higher % of the implants I put in are the inflatable type, and that's because satisfaction rates are actually much higher with the inflatable type. We're going to watch a video here in a couple of minutes after a slide or two, but basically you'll see this in the video, but it is comprised of three main components: a reservoir that's filled with fluid. We use saline, which in the event, not very common, but if there was any kind of leak in the system, your body would absorb it. It's safe and it's not going to harm you. That's connected to a pump that's placed in the scrotum, and that in turn is connected to the cylinders that are placed within the erectile bodies of the penis. And when you want to have an erection, you pump it up. It goes very, very rigid and hard. And when you want to go down, there's a button on the device to release the fluid back into the reservoir. The biggest thing here that I talk to guys about when they come see me are really sort of the overall risks and the benefits. I mean, I think the benefits are pretty obvious: consistency of the erection, getting firmness, not having a question in your mind whether or not this thing's going to work. But the downsides are the fact that it is a surgical procedure. There's always risk with any type of surgery. We go to great lengths to make sure that the surgical field is extremely sterile, extremely clean, because the biggest risk really in my mind to putting one of these devices in is if the device gets infected, it has to be completely removed. So then we go back to the OR, we take it out. It doesn't mean we can't put another one in the future, but then we're talking about, 2 to 3 procedures here for a man. The rates of infection are very low. They're less than 1%. They do go up in men with diabetes, especially if it's poorly controlled, men who are immunocompromised for some reason or another, men who have got a history of peripheral vascular disease or arterial disease. So we talk about all that as well. The device itself tends to work for quite a while before, the average device has a failure, which means either the valve in the pump fails or the tubing has a crack or fluid leakage out of it. That's somewhere in the realm of 12 to 15 years. And so for a lot of my younger men, we put one in and we say, well, hey, if you go strong for 12 or 15 years and maybe now we put it in when you're 55 and now you're 65 or 70 and you're still sexually active, we take the old one out and we just simply put a new one in, and that's a possible thing that we can do too. So we talk about all this. In general, surgery takes about 90 minutes. You can either go home the same day, or I tend to keep my patients overnight in the hospital. There's not a right or wrong answer there, but I like to make sure guys are comfortable after the surgery is done, at least for the first 24 hours. You need about 6 weeks before the device can actually be used for sexual activity. So I'm going to play you a video here real quick, just because I think it's useful to see the animation of actually how the device works. And this video is about a minute long, so I'm just going to kind of narrate it as it goes, but it's going to show you essentially an animation of what the device looks like in place and how it works as you pump it up. So right now you can see the man is pumping the device with the fingers. As he does that with each pump, there's a little bit of fluid with each pump that goes into the cylinders. Those cylinders fill, and once they reach essentially a pressure at which you can't force any more fluid into them, that you can't pump them up anymore. They're rigid, they're hard. And then you press the little button on the top of the pump and it makes that fluid flow back into the reservoir that we place inside the abdominal cavity. So in general, it's a fairly simple, device overall. A lot of guys ask me too, well, is this new? How long has it been around? I mean, this has been around for, about 40 to 45 years. It's something that has undergone a couple different iterations to make it safer, less prone to infections. But it's been well established. And I think the last number I saw is these devices have been put in well over 1 million men in the United States. And so they have a very strong track record of success. I know I got a lot of questions coming, and I think at this point, just because so many are coming in, I'm going to save a lot of those till the end. So I'm going to get through the discussion of incontinence, and then we'll come back and we'll go through each of those questions one by one. So with respect to incontinence, so I want to move on to that issue. And before I do want to say, as with the rest of the incontinence discussion here, if any questions come up in your mind that we don't address tonight, if you think to yourself, am I a candidate for the prosthesis? Am I a candidate for any of these other ED treatments? I encourage you to come and make an appointment to see me, just so that we can talk more about your specific case, because it is, we're speaking kind of broadly here tonight, but we do take a very personalized approach to every patient, and like I said before, what's right for one man may not be right for another. So talking about incontinence, incontinence is as big of a concern for as many men with prostate cancer treatment as erectile dysfunction. I would say that mostly when I'm talking about stress incontinence, which is the leakage that occurs after lack of support comes to a man in the muscles of the urinary sphincter, that's mostly going to be happening after prostate cancer treatment. All right, there are certain circumstances where a man might develop this type of urinary leakage not related to prostate cancer treatment, but by and large, I'd say well over 95% of the men that I see for incontinence of stress, stress incontinence, is because of prostate cancer treatment. There are other men who have incontinence more related to urgency and frequency that may be due to enlarged prostate or other things that are going on, or perhaps even a radiation history that's labeled more as urgent incontinence. But as far as stress incontinence, this tends to be the leakage that you have with coughing, sneezing, moving, sort of from the lack of support. 8 to 15% of men who have had their prostate removed will have ongoing stress incontinence after 1 year. So I almost tell every single guy that has their prostate removed, you're going to leak urine in the first month, the first 2 months. After that catheter comes out, the week after you have your prostate removed, you're going to leak some urine. But most men are going to recover that function, and they're not going to have any long-term leakage. But about 15% of them do, and those men are oftentimes going to require surgical treatment, because unfortunately there's no great pill or medication that can necessarily fix this type of incontinence. So other things that we can do, though, that we oftentimes will use early on are sort of durable medical equipment. Many men are familiar with using pads. In severe cases, more like full adult garments like Depends to catch urine. There are penile clamps that can be used externally to hold urine in. There are condom catheters. So, you're not having anything inside the urethra or the bladder, but a condom on the outside of the penis that will catch urine into a bag. But the downside there is you got to wear a bag around full of urine. And some guys, depending on their health status, their age, that kind of thing, that is the best option for them. But in men who are healthy, who are active, who are frustrated, who are not, getting the control of this incontinence that they want, there are surgical options. And we're going to talk a little bit about that, a little bit more detail here in a moment. I did want to just put a quick thing on the screen here for any guys, and I'll leave this up for a moment so that you can scan that QR code if you want to. But this is essentially a sort of a series of men who have had urinary incontinence after prostate cancer treatment, and they share their journey, and they share with you the frustrations that it causes in their everyday life, both physically and the mental toll that it takes on them, and then also their journeys to having that continence restored, and what a life-changing experience has been for them. So I encourage you to check that out. This is kind of in here just for completeness sake, but I do want to just use this slide to essentially, again, draw a distinction between stress incontinence, that essentially is the inability to hold your urine in because of the increased pressure that's being put on your bladder by everyday movements, by coughing, by sneezing, because the bladder is full, and because you don't have that support underneath the bladder anymore due to prostate cancer treatment, which can, like we talked about before, affect nerves of erectile function, but can also affect nerves and muscles of urinary continence. There's also urgent incontinence. That has to do with that type of leakage that occurs not just, when you stand up and it comes out all of a sudden and you don't feel anything. This is the type of leakage that happens where you're like, whoa, I got to go. I can't hold it. I'm got to run to the bathroom. And then before you can get there, your bladder's letting loose before you can get there because it doesn't have the ability to store that urine. And that oftentimes will happen with men who have had a history of long-term stress on their bladder, either from an enlarged prostate, from prior radiation procedures, from prior surgeries in the pelvis. Sometimes I see men for colorectal cancer that have had treatments, not necessarily just prostate. Sometimes it's men with history of bladder cancer, and we're dealing with that type of incontinence instead. So this is just a quick, overview. Again, another picture that I think tries to help us understand why incontinence occurs. If you look at the drawing there, the prostate, that pink organ is sitting right beneath your bladder. And when that is removed with surgery or treated with radiation, there is invariably going to be some type of at least small to sometimes severe collateral damage to the urinary sphincter that sits below the prostate. And when that sphincter is damaged, it can't coapt. It can't bring the urethra together any longer to hold that urine in. Once you get beyond that sphincter out towards the tip of the penis, it's just a tube. It's just a urethral tube. There's nothing to hold that urine in any longer. So once it gets past that spot, it's going to come out no matter what you do. The prostate itself, while it doesn't necessarily work to actively, provide continence, it is an important area of resistance to urine from coming out. The bladder neck right above the prostate also has muscles that are important in continence, and sometimes those can be compromised with prostate cancer treatment as well. So that's why we get this sort of issue to begin with after prostate cancer treatment. Bladder control problems in general can be caused by a lot of different things, right? And so that's also why I draw this distinction with men. And sometimes there's guys who have had their prostate removed, especially in guys with a history of prostate cancer removal and radiation, where we actually start to talk about things. And it's not so much that they're leaking because there's lack of support. They're actually leaking due to radiation-induced overactive bladder. And so it's important for us to understand the difference in those etiologies of the incontinence, because if we go in and we try to fix stress incontinence with a surgery, and yet you really are suffering from urge incontinence, it's not going to help you. Other things that we often see can cause this are side effects from medications. I would say that some of the biggest things I see in our diets are caffeine, alcohol, spicy foods, and acidic foods that can oftentimes be direct bladder irritants. Certainly neurologic disorders, Parkinson's, multiple sclerosis, prior stroke, that's a different sort of set of population that we've got to really evaluate closely as well. Radiation therapy, surgery, infection, those are things that we also obviously evaluate for too, like we talked about before. Again, this slide is kind of reiterating the proximity of the prostate and everything that's done to the urethral sphincter. The sphincter is very, very close, and sometimes, understandably, the prostate has to, or I should say the surgeon has to remove slightly part of the sphincter in order to gain adequate cancer control, and it puts men at a higher risk for developing incontinence down the road. For men who do develop stress incontinence and then go on to have relatively small amounts of leakage, there is an option to do surgery to place what's called a sling. Here on the screen, you see a picture of a sling, which is mesh arms, and this mesh is basically placed underneath the urethra during a surgery, and it essentially sort of hammocks and supports the urethra. So nothing real active is being done with this procedure. We're just putting some pressure on the urethra, to kind of put it simply, to increase the resistance so that when you are doing things like moving, coughing, sneezing, we don't have as much leakage. That tends to work best for men who are, typically using 1 to 2 pads per day. Sometimes we can stretch that definition up to 3 pads or so. If you put this in a guy who's just floridly leaking, he's going through 12 pads a day and wearing Depends and all that kind of stuff, it's not gonna work. But for the guy with slightly lower volume of incontinence, it can be a really nice option. For this procedure, what we do is we make a little incision in the midline underneath the scrotum. We dissect down to the urethra, and then we use the little the arms of the sling to bring them behind that bone there. You can see that's called the ischial bone, and we basically bring that sling up to tension it to make it tight. But that's just sort of a representation, pictorial representation of what that procedure would be like. In men who have more severe urinary leakage, the artificial urinary sphincter is the gold standard. This is in some ways similar to the penile implant in that it's got 3 components, but it's dealing with a very different function. There's a cuff that we place around the urethra. That's sort of the workhorse of the device. That's connected through a piece of tubing down to a control pump that we place in the scrotum next to the testicle, which is in turn connected to another reservoir, this what you can see there on the picture as the pressure regulating balloon. In the normal state, when you're just living your life, this pressure regulating balloon actually has a defined pressure that's been engineered to transmit to the cuff that keeps it shut closed around the urethra to cause it to clamp down. So that means when you're doing your daily activities, moving around, whatever, it clamps down on that urethra and it prevents leakage. When you want to pee, you got to reach down to the scrotum. You got to find the control pump and you got to hit the button right where that little sign is that says control pump on this thing. And that opens the cuff. It goes from closed to open, allows urine to flow through, and then it will automatically close again after about 30 to 45 seconds. And for most guys, that gives you enough time to empty your bladder. Sometimes guys got to hit a second time to fully empty. But the difference here between the sling and this is, number one, this can be better for control of higher levels of incontinence. But importantly, number two, it's also an active thing that you've got to do. You've got to reach down, you got to find and hit that button every time you want to urinate. So, again, men have to have good hand dexterity. They have to have the ability to feel through the skin of the scrotum. And not all men are good candidates for that. The other thing about this too is, the risk of malfunction is higher in this type of situation, particularly men with a history of radiation therapy. The risk of erosion of the device, which is the cuff literally causing a hole in the urethral wall over time and eroding through into the lumen of the urethra where urine is normally carried, that is also higher in men with a history of radiation therapy. And if something like that were to happen, we'd have to remove the whole device, give you antibiotics, allow you to recover from that. And, in many cases, we can go back and put another one in later. But it's a little bit higher risk procedure in some men in those circumstances. But I will say, this is the one procedure I've done for men that probably gives me the most satisfaction, because I've had more than a dozen men come back to my office and I activate this for them. And they're literally in tears and they're crying because they're so happy. They've been living wet. They've been living with odor. They've been living with the embarrassment of that around their friends and family. And it really can be a life-changing thing for them. So it's a really, really great procedure and a really great device for guys who are good candidates for it. So, similar to that penile implant animation, I wanted to just play you the artificial sphincter video as well real quick. This is just going to kind of reiterate what I talked about before with respect to the function of it. Again, with this implant, and we usually ask you beforehand, I always ask you beforehand, what is your dominant hand? And then I'll place the pump on that side. In this gentleman, it's on his left side, but we could just as easily place it on your right side. But when you'd like to urinate, you can see in that little inset up in the top left, when he presses the button, that cuff opens. Now it's kind of representing that staying open. And now automatically it's going to close back down again and squeeze on that urethra. And that allows you to then, without doing anything else, you can zip up, walk away, and you can be confident you're not going to leak any longer. I'm pretty careful to stress with guys, especially if we're taking a man from, he comes to my office and he's leaking through 10 pads a day, that if we put this implant in, I typically define success, as does all of the research studies that have been done on these devices, as getting you down to about 1 pad per day or less, right? When you're going from a lot of leakage all the way down to 1 pad per day, that's still a life-changing thing for a man. But I warn him, in times of really high stress, really vigorous physical activity, if you're overloading the intra-abdominal pressure, doing major heavy lifting, the device is designed to actually allow for urinary leakage in those higher pressure environments, because they don't want to trap urine in when it needs to otherwise come out. And so as a safety precaution, for some men, they are still going to have to wear a pad a day for what I call safety, just in case a few drops come out here or there. And so, one thing that I really wanted to stress to guys is that with these, both erectile dysfunction and stress incontinence, it's really an iterative process, meaning, what might not work in the beginning for you is not the end of the road. we oftentimes have to try 1 or 2 or 3 or even 4 different treatment options before we find what's right for you. And sometimes that's because it's either not working, we're dealing with side effects, or simply personal preference from a man where he, something does work and he's not having side effects, but he doesn't like having to take a pill or do an injection or whatever it might be. And so it's easier said than done, but I hope that I can stress to guys to not get frustrated if they're still struggling after they've tried, one option. There are other things that we can do to help in these circumstances. So, with that, I just wanted you to encourage you all to come and speak with me one-on-one if any of these topics that we've discussed tonight are of interest to you. If you feel like you're still struggling, or perhaps if you've had something done before, maybe you already have a sphincter in place or you have an implant in place, and yet for some reason it's malfunctioning, you're not satisfied with it, whatever it might be. There are things that we can do, to help you out with that. And so I did want to take a little bit of time just to go through some of the questions that we got tonight. Some of them I've already answered, but we'll kind of go through from the start. And so one person asks, is hormone replacement therapy realistic after prostate cancer and radiation? Yeah. And the answer is yes. And so I think sometimes you'll read about controversy in the hormone replacement space, the testosterone replacement space with respect to prostate cancer. But I think if we have a gentleman where we've proven that we have good control of their prostate cancer, meaning they've either undergone prostatectomy, radiation, or both. PSA numbers are either detectable or low and stable in the case of radiation, that we can safely give testosterone replacement therapy to these men, and it can improve their quality of life without increasing their risk of recurrent prostate cancer. Now, that's not true for some men with higher risk prostate cancers who are on androgen deprivation therapy, which is quite frankly trying to achieve the opposite, which is to reduce your testosterone levels. And so I can't say blanket statement that's true for every man, but in certain circumstances, yes, testosterone and hormone replacement therapy can be realistic for men after they have prostate cancer treatment. Another person asked, any advances in surgical mechanical procedures to virtually eliminate incontinence? And, unfortunately, not any advances, so to speak, in terms of, what the procedures that I have to offer. And that's primarily because these types of procedures have been around for a long time. One of the things I didn't talk about is there are some newer procedures out there for men after they've had their prostate removed that you might see where they're inserting balloon type devices, not around, but next to the urethra, that sort of thing. Those types of procedures have shown a little bit of early promise. They're not exactly into what I'd consider prime time yet. I think a little bit more research and data need to come out on their efficacy, but it is possible that those will become better vetted and more, more of an option over time. I think the other question someone else asked, what's my position on testosterone replacement after radical prostatectomy? And I think I already pretty much answered that I'm open to testosterone replacement. When we have men on testosterone replacement after prostatectomy, we are monitoring not just their testosterone levels, but we monitor their PSA levels at least every 6 months. We monitor other hormone levels, blood counts, kidney function, liver function, to ensure that, that testosterone levels that we're providing them are safe. I think of it this way. And a man who's got low testosterone, the goal is to provide him with normal physiologic levels of testosterone, whether or not you've had your prostate removed, whether or not, whatever the etiology is for your low testosterone. I think the danger comes in when men are on testosterone replacement and they're achieving levels of 1,300, 1,400, greater than 1,500, which is off the charts high for what a normal man's testosterone should be. Then I think we get into some situations where it may not be so safe. But as long as we are doing it safely with proper monitoring, it can be a good thing for men. Do the pumps damage blood cells? No, to my knowledge, no. So if we're talking about the external vacuum erection devices, no, the pumps don't damage blood cells. I certainly could understand an experience where a man, if they're being overly vigorous with a pump, you could cause yourself some bruising and swelling and that kind of a thing, just from the vacuum device itself. But I've never seen or heard of a case where that's going to cause permanent damage. Next question. There's been a lot of controversy with Viagra and Cialis regarding their use over time and negative physical outcomes. What are your thoughts on what's advertised on TikTok and Instagram using all these different erectile enhancement and long-acting erections? So I got to be honest, I'm not on TikTok. I'm on Instagram to look at pictures of my kids and my friends' kids and my family members. So I don't know specifically the sort of the negative physical outcomes and the controversy in this space on TikTok. I certainly could speak to a more specific question on that if it's up there, but to be honest, I've been, for most men, right, I've been prescribing these medications for a long time. I haven't seen any major long-term concerns, but I kind of leave it at that just because I'm not exactly sure what it's in reference to. Insurance coverage, that's a great question. We hear that a lot. And actually, insurance coverage is quite good for implants and artificial sphincters. The implants that we put in, anytime we put them in, we get prior authorization. We make sure that we have authorization from the insurance company before proceeding. In general, I tell guys to expect to pay out of pocket whatever their deductible is, because these implants are expensive. Just for the device itself, it's about $16,000 to $20,000, and then you add the anesthesia cost, the OR cost, hospital time. It can run up to $50,000, pretty quickly. And for that reason, a man's going to reach his deductible. So we would make sure. There are rare exceptions where certain specific insurance plans will have denial for sexual function. It's not common, but it does happen occasionally. But we would of course make sure that we get that approval before proceeding, so that you have an understanding of what the cost is going to be for you. Let's see. So another man asks about the effect of, he's struggling with erections after prostatectomy using a vacuum erection device, and that, wondering whether or not he should be concerned because it's been about 6 months and he still hasn't had return of his erectile function. And I would say that I do think it's a good idea to use a vacuum erection device. There are programs called penile rehabilitation programs that oftentimes will focus on the use of regular oral PD-5 inhibitors like Viagra, Cialis, plus regular use of a vacuum erection device to try to draw blood into the penis and make sure that we're getting good oxygen flow to the penis, even if we're not having usable erections for sexual activity. And there is some evidence to suggest that can be helpful. At 6 months out, I think while it's 6 months and that feels like a long time, it's still definitely possible to have some recovery after that time. And so I would say don't get too discouraged at this point. But it is true that if you're really having zero erectile function at about the 6 month mark, there's probably a greater than 50% chance that by the 12-month mark, you still may have less than sufficient erections. And then we might need to be talking about other therapies there. One person wants to clarify about the effect of the implant on the shaft versus the head of the penis. And it's true, that when we put the penile implant in, it's going directly into the erectile bodies. The erectile bodies, the tip of the erectile bodies will kind of end and extend all the way to the middle part of the head of the penis. But when you get a normal blood erection under circumstances before prostate cancer treatment, for example, you get engorgement of those erectile bodies, but you also get collateral engorgement of the head of the penis and the urethra on the underside, which is called the sponge. And those areas will not necessarily get full or plump just by use of this device. So it doesn't actually affect the head of the penis, although some men will still have a little bit of residual blood flow during sexual excitement and sexual activity where they will still get some plumpness there. And so the implant is doing the bulk of the work in terms of the rigidity, but it does not directly affect the head of the penis. How long after hormone treatment can you recover, if ever? So, hormone treatment is, and I don't know if they're referring here to actually like hormone, like androgen deprivation, and then once stopping it, how long might it take to recover? But if that's the case, Some men may never recover erectile function if they've been on hormone deprivation therapy for, 2 or 3 years, for example. Some men can, but to be honest, it's going to be tough to have recovery, several years later if you've been doing it for a long time. So the time that you've been on that androgen deprivation therapy also matters. Some men are only placed on it for 6 months and then they're done. Some guys need it for 2 to 3 years. Other guys, it's recommended lifelong. Some guys don't need it at all. So, the answer to that question is somewhat variable. 18 months after removal of prostate, one gentleman still having to wear 1 pad a day. He went to physical therapy. That's another thing I didn't really touch on, but we do send patients to pelvic floor physical therapy. And he's asking what else he can do. I think at this point, if it's been 18 months, you're still having 1 pad per day, you've been to physical therapy. Quite honestly, the only other thing that you could probably do is go back to physical therapy to give it one more try. And if you feel like you've already done that, there's a good chance that, you may be living with that 1 pad a day for the rest of your life, with the exception of if we do surgery to correct it. One of the challenging things here is there is no good medication. I mean, medications have been tried. Imipramine is a common one that I'll see men placed on for stress incontinence. It doesn't work. Pills really don't work to help this problem. It's a structural muscular problem, a nerve and muscle problem that really can only be fixed with surgery when you're that far out. After a year, if you're not making progress, you've been through physical therapy, the only way, in my opinion, to really fix that would be surgery. Similarly to incontinence, I hear a lot guys are having expression of urine, right, during sexual activity. And that's very, very common too. So, some guys are going to leak when they cough, sneeze, move around, whatever. Other guys are going to essentially ejaculate urine when they have an orgasm after the prostate's been removed. And then sometimes that can happen, again, because of lack of support in the way that the muscles are working during orgasm. And so, that can be a very, very common thing that we see in men after prostate removal. And we essentially have to treat that like any other form of incontinence. I mean, it's basically happening because there's lack of support for the urine to be held into the bladder. And so it's leaving the bladder during orgasm. And so similar to other urinary incontinence, if that's causing major problems, then sometimes we do have to do surgery to fix that too. With a sling, for example, that would be a good sling candidate. One patient was mentioning that they had testicular cancer 28 years ago, prostate cancer as well, and the left testicle was removed. And asking if this will affect erectile dysfunction. The answer in any individual is I don't know for sure. When you lose a testicle for any reason, it is very possible that the remaining testicle will take on the extra burden and it'll actually grow a little bit. It can be capable of supplying adequate amounts of testosterone without having to have replacement therapy. But then we also add in the prostate cancer surgery. And so there's another variable there. And so, it's hard to say in any one individual, will it definitively affect it, but could it affect it? Yeah, it absolutely could. And so if you are affected, then that would be something to, if you're struggling with erections, that would be a reason to come in and see me to talk more about it. I'm just going to scroll through a couple other questions. Some of them are duplicates, so just bear with me as I read through them here. So one person asks, is removal of the prostate that actually produces the substances to facilitate sperm motility and quality also cause erectile dysfunction? So they're not really directly related. So the prostate is responsible for producing it's responsible for producing proteins and fluid that is very important for our semen, but it doesn't actually produce sperm. The testicles produce sperm. Sperm is stored in our seminal vesicles. When you have your prostate removed, your seminal vesicles are removed with it. And so for that reason, when you have a prostatectomy, you are in effect being given a vasectomy. Not exactly, but that's essentially what's happening. You're cutting off the flow of sperm out of the testicles to the urethra. And so you will not, when your prostate's removed, you won't have ejaculate anymore and you won't have sperm anymore. but that's technically a separate process from what is responsible for erectile dysfunction. But they oftentimes go hand in hand. Can you have both an AUS and a penile implant? In short, yes, you can. Those can be put in at the same time in a single surgery or in stage surgeries. I typically do them separately just because I think that it can complicate things a little bit doing them the same procedure. Oftentimes putting both devices at risk if something were to go wrong. So I usually ask the man and talk to them. We have a conversation about which one is most important to them. And sometimes you can't pick one. They're both important, but we usually do it in a staged procedure where I do one, we wait 6 months, and then we come back and do the other one. What is the percentage of surgical removal versus radiation treatments performed? That's really about 50-50. If you look at the American Urological Association guidelines for prostate cancer treatment, surgical removal and radiation therapy are essentially presented equally. And that's because when we look at the data of cancer control and cure for prostate cancer, they're essentially identical. I do think there's a day 20, 30 years from now as technology advances, hopefully, where we're doing fewer prostate removals and more targeted therapy for men with prostate cancer with fewer side effects. But right now it's about 50-50. What percent of men who have radiation develop incontinence? If it's just strict radiation, if you haven't had your prostate removed, that number is probably about 5 to 10%, maybe even a little less than that. And that's not going to be the stress incontinence typically. That's usually going to be the urge incontinence that's happening due to what we call radiation cystitis, where the bladder is just very irritated from the radiation. So it's for isolated radiation therapy, not that many. Do the implants shorten the length of the penis? This is a great question. And I say that because it's a big part of the conversation I have with guys. The implants themselves do not shorten the length of the penis. When we put an implant in, we directly open the erectile body. We measure the erectile body internally, all the way to the tip of the penis, all the way internally down into the pelvis. And we custom fit the device to every man within 5 millimeters of their penis, because that's the increments that we have to play with in terms of the customization of what the manufacturer gives us. We also, of course, put in the biggest implant we possibly can. So the implant itself does not shorten the penis. With that said, a lot of men, what they're kind of comparing their length to post-operatively is what they had before their prostatectomy. And so prostatectomy itself can shorten the length of the penis. Penile atrophy, meaning that, the penis hasn't necessarily had a good erection. Oftentimes I see men 5 or 10 years after they had a prostatectomy and they haven't had a good erection for just as long. The penile tissues atrophy and the penile tissue shorten. And that's a big reason for it as well. When we look at a patient preoperatively, I demonstrate to them what's called stretched penile length. And that's taking the penis during an exam, taking the head of it, pulling it away from the body as far as we can. And it's going to stop at some point, right? It's only going to go so far. And that is essentially the length of the penis that you'll have with an implant in, fully inflated. So, for a lot of guys, they look down and they go, okay, yeah, that's not what it used to be. But I also want to have realistic expectations and what we can achieve with the implants. It's not going to make you bigger, but it's also not going to it's not going to make you smaller. But I think a lot of guys do perceive that it does because of where their reference point is, which is usually what they're thinking they were pre-treatment for prostate cancer. Is there any hope for erection after salvage radiation with ADT? There is hope, but it's challenging. This is a patient, when we talk about salvage radiation, that means typically, if I'm using and interpreting your language correctly, that's a man who's had prostate cancer. They've had their prostate removed. They've had biochemical recurrence or local recurrence of the prostate cancer. So then they go on to have radiation therapy and hormone therapy to treat it. And now you've been sort of given the triple hit, right, between the prostate removal, radiation, and hormone therapy. And that's very difficult for any man to have an erection. It's just simply, physiology. And so while those things don't guarantee that you don't get an erection, that you develop erectile dysfunction, if you already have erectile dysfunction and you've undergone those treatments and are currently having hormone deprivation or androgen deprivation therapy, I never say never, but it's going to be a challenge. And those are men who I oftentimes are going to see for an implant because we give them time. Some guys are going to be on hormone therapy for a long time, and we don't necessarily even want to give them that time because they've already been dealing with this for 3 or 4 years by the time they've had recurrence and radiation therapy now. And at a certain point, we just want to give them their quality of life back, and that's when we might move towards an implant. Is hormone therapy okay in 77-year-old BPH? I mean, yeah, in general it is. Yes. I mean, it is true that testosterone replacement will stimulate the prostate a little bit. It can sometimes elevate your PSA number slightly. It does not, in my opinion, put you at increased risk for developing prostate cancer. General question is yes, but again, in any individual, I can't answer that question specifically without knowing more information. With the surgery inserting the tubes, assuming the implant will you have normal ejaculation? So yes, to the extent, if you've had your prostate removed, like we talked about before, you won't have fluid come out for ejaculation, but you will still be able to achieve orgasm. The surgery does not enhance sensation in orgasm. It also doesn't detract from it. And so, if you're talking about a guy who already has his prostate still in and is able to ejaculate currently, they'll be able to do so afterwards. But if you had your prostate removed, you're probably not having ejaculation. You're not having, when I say ejaculation, I mean fluid coming out. Then you're not going to have that either. CPT procedure code for artificial sphincter. I don't know off the top of my head. You can definitely Google it. I could probably find it real quick, but I'm going to go on to some other questions. I'll come back to that if we have time. What can be done about atrophy after AUS has been for several years and systems not effective? That's a great question too. What this patient's referring to is urethral atrophy, where essentially by having a sphincter in place around your urethra, it kind of just it's causing constant pressure on these tissues. And in cases where we've actually gone back and removed sphincters, you can actually see the urethra kind of comes down where the sphincter used to be at bottlenecks, and then it goes back out, and the tissue is essentially atrophied, and it's not as pliable, it's not as compliant. A couple of things that can be done in that case. There are some people who, it's a bit of an area of controversy within the urology world, some people who might increase the pressure, go in and increase the pressure of your pressure regulating balloon. But in my opinion, the best thing to do in that case, if you truly have urethral atrophy, which we'd have to try to diagnose with a couple of tests in clinic, would be to remove the device, or I call it revise the device, but have to move the cuff to a new place on the urethra. So move it up or down to a new healthy spot on the urethra to try to regain that coaptation and get that thing, coming together again. Is it normal for older men to not care about ED malfunction? Yeah, I mean, it is, right? I mean, there's a season for everything in life. And for some guys, I talk to them and they clearly have erectile dysfunction, but, it's not necessarily the forefront of their being, the forefront of their day. And that's okay, right? I stress that to every guy. What's important to one man is different for another guy. And I can take two guys with the same experience, the same surgery, the same symptoms, and they want two totally different things. And so what's right for one guy is not going to be right for another. And I would never tell a man that he needs to be worried about his erectile function, right? I mean, you don't need to be. It's not something that is essential for your life. For some guys, on the other hand, it's a huge part of their quality of life, their confidence, their sexual relationship with their partner also leads to, not just physical intimacy, but emotional connection and intimacy. And, for other men, it is a big deal. But if it's not for you, that's okay. And the last question here, if you don't have an erection for many years, does it affect the penis since no blood's going there? Yeah, I mean, I think that gets down to the issue of atrophy, essentially. Penile tissues can atrophy. They're not getting good blood flow to them. It's hard to know, though. This is a little bit of the chicken and the egg phenomenon. I mean, are you not getting erection because you haven't had blood flow there for a long time, or is the actual act of not having blood flow there causing the erection? And I think it's a little bit of both. But I do think that the longer you've had that happen for a number of years, the harder it is for it to just spontaneously recover, or even recover with some of the, more like lower tier therapies like, oral pills and things like that. Real quick, if that gentleman is still on the call while we were talking, I Googled CPT code for AUS 53445. So you might also see a 53444, but it's somewhere in there. And that's the kind of the main thing that you'd want to use. These are just codes that insurance companies use to know how to build a procedure. So yeah, I think that pretty much covers everything, all the questions that I could see here. I really appreciate everyone logging on tonight. I have to say I'm impressed. There's still 116 people logged on. Thank you for sticking it out with us tonight. I would encourage you to please, if you have further questions, request an appointment and come speak with me. I wish I could talk to all of you one-on-one tonight, but there's just far too many and too little time. And so we can get you in to see me if you need assistance with any of these issues. If you know a friend, a family member, or anyone else who has questions, I am more than happy to speak with you guys in the clinic, and we will get you the evaluation, the help that you need. So I hope that you found this talk informative. I'll try to do these from time to time, 1 or 2 each year, just to try to, get this information out there. Thank you very much for your time, and have a great evening.